Welcome, everybody, to today's acid-base conference. We're continuing on, I think this is part 6 or 7, on metabolic alkalosis. And again, the reason is the understanding of this acid-base disorder is the most complex in clinical chemistry and in nephrology. Okay, so today we're going to be focusing on a different level of what we've been talking about before, and that is the entire tubule transport machinery that's involved in metabolic alkalosis. And just to refresh your memory, over the last number of weeks, we've gone through all the known factors that will appear in different papers. None of this will be in any one paper. No one's ever written a review that includes everything that we've covered over the last number of lectures, but this slide summarizes what you will find in the literature. And today, you will see as we move along, we're going to be actually talking about sodium within the lumen of the tubule. Okay, so we'll start off with a case. This is a 51-year-old female who was hypertensive despite being treated with a number of different meds. And if you look at her chem panel, you can see she was hypokalemic. Her total CO2 was 32. She was not volume depleted. So if you're thinking metabolic alkalosis, which the numbers are compatible with when we look at the PCO2 and bicarbonate, it looks like a compensated metabolic alkalosis. Remember the normal levels that we start to get the delta bicarb and the delta PCO2. It's a female, so the normal PCO2 is not 40, it's around 37, and the bicarbonate's around 23. So that's where you get your deltas from. And you'll see that the ratio of the delta PCO2 to delta bicarbonate is about 70%. So the bicarbonate went up, or the PCO2 went up about 70% of what the bicarb went up, and that's only compatible with a compensated metabolic alkalosis. And because there's no pre-renal failure, right away you're already thinking this might be a renal cause. And plus, as I'll show on the next slide, the patient's hypertensive. So right away, that really narrows down what's going on. And on an exam, this is how you have to think, because you don't want to be pondering every single cause of metabolic alkalosis. There's enough clues here to really zero in on what the pathogenesis is. And the renin and aldo are suppressed. So we're dealing with hyporenin, hypoaldo, but with metabolic alkalosis. Now, probably most of you, if I said hyporenin, hypoaldo, you'd say type 4 RTA, or an aldo type of hyperkalemic distal renal tubular acidosis. But as you go along in nephrology, you'll see the renin and aldo can be anything in different acid-base disorder. And here's a very nice example. And we actually covered this in past talks of low renin, low aldo, but metabolic alkalosis. So when you have a metabolic alkalosis, you hopefully know by now that you divide it up by chloride sensitivity, and that's a therapeutic subdivision. In other words, there's a group of patients you give chloride to and everything will go away. And there's another group you can give as much chloride as you want and nothing will change. And that's important to know because you don't want to be giving chloride to everybody. So you can predict who's chloride responsive and who's not based on the urine chloride concentration or the fractional excretion of chloride or the 24-hour urine chloride. The point being that in the chloride sensitive group, the urine chloride excretion is low. And by low, it means relative to their dietary intake, because obviously your chloride excretion could be very low too if you went on a very low chloride intake. So it's not that it's low in an absolute sense, it's low relative to the intake. Now, problem is we never know what the intake is, but we assume the intake is 100, 150 milliequivalents a day on an average North American diet. So if we get an excretion rate of 20 or 30 or 40 or a low concentration, then we can say that it's going to be chloride sensitive. And what we're doing is we're repleting the body of chloride, at least in a whole body sense. What we're actually doing is improving the chloride delivery to the cortical collecting duct so that pendrin can work, as we talked about a number of times, and increase bicarbonate secretion, it being a chloride bicarbonate exchanger. And it's very dependent on the luminal chloride concentration. Okay, so that's the chloride sensitive group, and they typically are extrarenal. the majority, and the blood pressure tends to be normal or on the lower side. You don't get hypertensive, chloride-sensitive, metabolic, alkalotic patients. So if you see that they're chloride sensitive, it's coupled with a lower blood pressure all the time. Now, the only renal cause of a chloride-sensitive metabolic alkalosis is if someone was taking diuretics, either thiazide or loop diuretics, and they stopped taking the diuretic. Once they stop, and assuming you were right there when they stopped, because if you just stop and do nothing, it'll correct on its own. But it's correcting on its own because of the patient going into positive chloride balance. So the point being that if the diuretic was stopped and then you give the chloride, they'll respond to that. The bicarbonate will drop. If they're still taking the diuretic, you can give as much chloride as you want, nothing's going to happen. So that's really the only subtle scenario where you can have a renal cause, but it's chloride sensitive. In a certain sense, it's not a renal cause anymore once the diuretic was stopped. It's a historic renal cause. There's no ongoing renal cause where it's chloride sensitive. So it's sort of a funny situation. So with diuretics, remember for your exam, it can be chloride sensitive or not, or chloride resistant. If they're actively taking the diuretic, it's chloride resistant. If they were taking the diuretic as a cause of the metabolic alkalosis and they stopped it, that's when it becomes chloride sensitive. So it can be both, and it's confusing. Now, as far as the chloride resistant causes, those are always renal, and we divide up the patients by blood pressure. So the blood pressure can be normal to low, or it can be high. So in this patient where we had blood pressure high with a metabolic alkalosis, we don't have to give chloride to find out, or we don't even have to measure the urine chloride, even though in the real world you might want to do that. You know it's going to be normal. It's not going to be chloride sensitive. There is no hypertensive, chloride sensitive, metabolic alkalemic patient that's been described. So when you see these findings, not only should you be able to, without doing anything fancy, just from the clinical case, say that this must be a renal cause, but because the patient's hypertensive, you know exactly where in the nephron the transport abnormality is too. You have to get to that kind of level of sophistication if you're really going to understand what's going on. So the red square here shows where in the nephron. And again, it's incumbent upon you to learn the segments of the nephron. Don't just, when you graduate, say proximal and distal tubule like you did when you were a medical student. You really want to get to the point where you understand the anatomy of the nephron. Only then will you be able to understand the individual transport processes within the segment and what each cell is doing within the segment. No, it's really, it's like understanding chemical engineering. You really have to understand the anatomy. So the segments that we're talking about that could be causing this are called either the connecting tubule, CNT for short. It's right after the distal convoluted tubule, or the cortical collecting duct, which is called the CCD. The cells are quite similar in both. There are some differences. For today's purposes, we'll just call it the cortical collecting duct. Okay, so that's the name of the street, but what houses are on that street? Those are the houses being the cell types, the cells. Well, first of all, this patient had Little syndrome, and Little syndrome is caused by mutation. Little syndrome involves the ENaC sodium channel, and ENaC is made of three different proteins. It's three different genes expressing three different proteins that are all assembled in the cell, and they create what's called the ENaC channel. And ENaC just stands for epithelial, Na is sodium channel. So it sounds fancy, but all you're saying is it's a sodium channel in an epithelial cell, but it's a specific type of sodium channel. It's made of three subunits. Each of these has two transmembrane domains and an extracellular loop between them. Alpha, they're called alpha, beta, and gamma. They could be called anything. But the point is that three different proteins that self-assemble, and this whole thing as a unit transports sodium. And the configuration here, this is the outside of the cell, and this is the cytoplasm. Now, in this particular case, this protein is on the apical membrane, or the urine side of the cells. Remember, the cells in the nephron are polarized. It means that they have two different membranes that have different proteins on them. It's not like a red cell that's symmetrical. What allows the kidney to transport, or the nephron to transport, is it has cells that are called polarized, which means that the function of the apical membrane is different than the basolateral. Apical is the urine side, basolateral is the blood side, and they have different functions because they have different proteins. If it was symmetrical, it would never be able to transport from one side to the other. So this protein, or this channel, is in a particular configuration in the cell on a particular membrane. It's on the apical membrane of the cell. So it's been known for years to be caused by heterozygous mutation. So it's autosomal dominant. You only need one allele. Okay. So if your father's normal and your mother has littles, you have a 50% chance of getting littles. It's not autosomal recessive, and it can be mutations in any of these three subunits. Now, the mechanism in most of the mutations is a degradation problem. So all proteins in our body are made and destroyed. It's called turnover. And that determines in the steady state how much of the protein is there. If you increase the degradation and do nothing to the production, it's going to decrease the amount of protein. If you increase the production and don't increase the degradation, you're going to have more of the protein. So either of these rate constants can be involved. In this particular case, they have a problem with degradation, but the production is not affected. So they end up in the steady state having more ENaC channels in the membrane of the cell. It's not that the function per molecule is affected, there's just more of them. And at least with most of the mutations, and it tends to be due to the fact that the mutation, which it's typically in this is the N terminus, or the end of the protein, the C terminus of the protein has a motif called a PY motif that this enzyme E3 ubiquitin NED4 tube binds to. And that's a very important event to occur to take this whole protein to the lysosome to degrade it. If this can't bind to the PY domain, the protein just stays in the membrane longer. And you're still making some, so you end up in the steady state with more of them. So they're degraded much more slowly. That is by far the reason that Little syndrome is created. It's a problem degrading ENaC channels. So the result of the inhibited breakdown is that you have more of the protein on the apical membrane. If you did a Western or you did immunocytochemistry of the cells, you would see more of the protein. You don't change the intrinsic function of the channel. Okay. Now, ENaC is found in the cortical collecting duct that I showed you before in a particular cell type in the cortical collecting duct. And this is a scanning EM of the cortical collecting duct. We're actually sitting in the lumen of the tubule. So just to give you an idea of dimensions, from this side to this side is about 20, 30 microns. Very small. And the urine flows down here at a rate of nanoliters per minute. Very, very slow. The principal cells, as I mentioned before, can be recognized. They have a polygonal shape, plus they have one central cilium. You can see it coming out here, and it's floating around in the lumen. This, again, we're looking at the urine side. It's floating around in the urine, and people think this is a flow transducer, that it actually moves, or the movement changes with different rates of flow, and that then is transduced to signals within the cell that allow the cell to alter its transport properties. So this is actually a flow sensor. People think it's quite fascinating. The other point about this tubule, as I point out, is that it doesn't have one cell type like the proximal tubule does. I mean, the proximal tubule has different sections because within that section, the cells are different. It's so-called S1, S2, S3 proximal tubules. Plus we have superficial and juxtamedullary nephrons. So an S1 tubule in the superficial part of the cortex is not the same as a tubule in the juxtamedullary part of the cortex. So there is that difference too. But this tubule is unique in many ways in that it has within its length different cell types with different functions. And we'll talk about that in a minute. But let's focus on the principal cell now, where the ENaC channel is found. And this just shows you the machinery within the principal cell that allows it to transport. So let's go through this slowly. First, as far as orientation, on this side is the urine side. This membrane is called the apical membrane or the luminal membrane. So this part here is inside the center of the nephron. And then we've got the blood side. ENaC is sitting on the apical membrane. So these two lines just are to depict a channel. There's nothing fancy. And sodium goes through here from outside to inside. It's going down a concentration gradient. So the sodium in the lumen is 40, 50, 60, 70. It's not like blood, but it's definitely higher than inside a cell. The cells in our body have an intracellular sodium of 10 to 20 milliequivalents per liter, much less than blood. So there's a gradient here for sodium to enter. And as we'll talk about in a minute, there's an electrical gradient across this membrane for sodium to enter also. So there's electrical driving force thermodynamically and a chemical driving force. And we combine the two when we're talking about transport into what we call an electrochemical gradient. Now, on the outside is a receptor for mineralocorticoids. That's where aldo binds, and we'll talk about what that does. But it changes the biology of the cell as far as the number of transporters and their activity. We have an electrical gradient across the cell on the apical membrane of about 10 millivolts more negative inside than outside. And we'll talk about that in a minute because this is really key to understanding how sodium and potassium are transported in this segment and how aldo works. There's another protein called a ROMK potassium channel. Again, it sounds fancy, but it just stands for rat outer medullary potassium, where it was cloned from. So the outer medulla is the part of the kidney below the cortex. And then you have what's called the inner medulla. So it was found in the outer medullary portion of the kidney. And it is the potassium channel that is responsible for potassium secretion across the apical membrane into the lumen. So these are two totally different proteins. Now, we all know that aldo and amiloride, by the way, binds to the ENaC channel. That's how it works and blocks it. Little syndrome is sort of the converse of being on amiloride. Other drugs that bind ENaC are triamterene and pentamidine. You might remember that. You might need to know that for your exam. So ENaC can be blocked by those drugs, but its function in total is increased in little syndrome just because you have many more of these in the membrane because the degradation is poor. Now, the important next point to memorize is ENaC and in particular sodium transport through ENaC is the key factor for controlling this apical membrane voltage. And what do I mean by that? When ENaC goes in or doesn't go in, it changes the voltage. Now we'll talk about why that's important because it has very important effects on K transport because potassium sees this voltage. We'll show that in more detail in a minute. Now, for those of you that might recall some electrophysiology, either as an undergrad or in medical school, if you have a positive charge going into a cell across a membrane where it's negative inside the cell, that's going to make the negativity less, and that's called depolarizing the voltage. And that's what occurs when you have enhanced sodium influx across ENaC into the cell. You depolarize that voltage and make it less negative. On the other hand, the converse would be giving someone amiloride. When you give someone amiloride and block the sodium entry, you prevent sodium, a positive charge, from going across that membrane, and the membrane becomes more negative inside, and that's called hyperpolarizing it. So you would see, and this is just, a cartoon example, the normal apical membrane voltage, let's say, is -10 inside relative to outside. It's always relative. There's no absolute voltage. It's comparing two compartments all the time. So it's 10 millivolts more negative inside compared to the lumen. When we let more sodium in, we make it less negative compared to the lumen. When we prevent sodium from coming in, we have it more negative compared to the lumen. So this voltage is dynamically changing in all of us from time to time, from second to second, depending on how much sodium is coming through ENaC. That's the important take-home message. So changes in sodium transport through ENaC will affect this number. More sodium coming in makes it less negative. Less sodium comes in makes it more negative. Now, the reason that's important is that potassium going through the wrong K channel sees that voltage too. And that's how they're coupled. That's how, when you give aldo, you increase sodium absorption, and then the sodium absorption changes the voltage and makes more K come out into the lumen. That's how aldo gets rid of K in the chordal collecting duct, or how amiloride causes hyperkalemia. So that's shown here. So if you have a situation, for whatever any reason, you make the voltage less negative. When the voltage is less negative, you enhance K efflux. When you make the voltage more negative, you impair K from leaving. So let's look at that again. When sodium comes in an enhanced fashion, you make this less negative. Now think of what K is seeing. K is always going against an electrical gradient. The potassium here has to go from a negative to a positive side. It's always having a problem coming out. Now it does have a chemical gradient, which helps. The potassium in a cell is 100 milliequivalents per liter, typically 100, 110, compared to the outside. In the lumen, it's like 20, 30, 40 milli, but there's a potassium gradient to come out. But it's fighting an electrical gradient all the time. So the reason having more sodium enter enhances K secretion is when sodium comes in, it will make this voltage less negative, and K has less of an electrical gradient to come out again, and you enhance K secretion. Okay, so that's what's going on. That's how they're coupled. The less negative this is, for whatever reason, the usual reason is enhanced sodium entry. You get more K secreted into the lumen, and then more K excretion in the urine. That's what we're assessing when we're assessing TTKG. You're assessing K secretion via the principal cell in the chordal collecting duct. TTKG is actually a principal cell function test, like a pulmonary function test. It's not a nephron function test. It's specifically what's going on in the principal cells. So on the other hand, if we give someone amiloride, we block sodium entry, we make this voltage more negative, and now it's even harder for K to come out. So there's less K secretion, and the patient goes into positive K balance because their intake's the same, but now their excretion per unit time is decreased, so they become hyperkalemic. Okay, so sodium is a key factor in determining what this voltage is. And this voltage is a key factor in determining how much K is secreted per unit time. Those are very important points to understand. Okay, so depolarizing that voltage enhances K secretion or K efflux across the cell membrane, and hyperpolarizing the cell decreases K efflux. So what's going on in Little syndrome? Well, in Little syndrome, we have a ton of sodium coming in, so the voltage is now depolarized. It's -2, -3 as an example. No one's ever measured it in a patient, obviously, but it's depolarized. And that then is going to decrease the electrical gradient that K has to fight against to get out. So it enhances K secretion via ROM K. And the 24-hour K excretion, when it was first created, is now exceeding the patient's intake. So they have negative K balance and they become hypokalemic. Okay, so the picture in Little syndrome looks very different. Now let's go back to our patient. Our patient, yes, had hypokalemia. Now we can say this is due to principal cells hypersecreting K because of the fact that the apical membrane voltage in the principal cells is now depolarized. So we have an understanding of that. But what we don't understand and haven't talked about is, why does the patient also have a metabolic alkalosis? What does ENaC and depolarizing the apical membrane voltage in the principal cell have to do with acid-base balance? And that's what we're going to talk about in the next slides. So again, we have a metabolic alkalosis here. In fact, we talked about that as far as our clue that this must be a renal cause with the hypertension. Well, let's go back to the principal cell. Excuse me, let's go back to the cortical collecting duct. Maybe we'll find some clues. Well, the first thing we know a priori is there's not one cell type. We know there's principal cells, but the transport machinery I showed had nothing to do with acid-base transporters. We didn't show a proton, we didn't show bicarbonate, didn't show hydroxyl ions, but maybe it's not the principal cell. And that's in fact the case. So there's 3 different cell types in the cortical collecting duct. And you can almost see that morphologically. You can see these cells here. They just look different. They're more circular. They have all these things on the surface, which you don't see on the smoother principal cells. They don't have a cilium. These are, by the way, are outpouchings, worm-like outpouchings from the apical membrane into the urine. They're called microplici. So maybe that's the clue that we have a different cell type, and maybe that cell type is involved. So let's go through the causes. It's now known that there is increased proton secretion coupled with bicarbonate absorption in what's called the type A intercalated cells. So one of those cells with microplici are called intercalated cells, and intercalated cells are subdivided, as I'll talk about in a minute. And there's one called the type A intercalated cell, and it's the cell responsible for acidifying our urine. In fact, when you give someone a Milleride, that's why you get a distal RTA. When you have congenital genetic causes of distal RTA involving the proton pump subunits, it's this cell that's not secreting protons. Now here, that can't be what's going on. It would seem like the opposite's going on. We must have enhanced proton secretion if we have a metabolic alkalosis, and that's indeed what's going on. So it's the converse of distal RTA, what's going on here, as far as the function. But remember, this function, when we think about it, must be secondary, since the primary cause is the ENaC sodium channel in the principal cell, and there are no ENaC sodium channels in the type A intercalated cell. So what could be going on? Well, let's make the transport machinery even more complex. On top, and this just shows normal, not little syndrome. On top, we have our cartoon of our principal cell, and on the bottom, I've drawn a type A intercalated cell. And this is overly simplistic, but it shows you the differences. First of all, there's no ENaC and channel and ROMK channel, but this cell does have acid-base transporters. On its apical membrane, it has a vacuolar proton pump, shown simplistically here with an H+. It's actually produced from 16 different genes, making 16 different proteins that actually self-assemble and turn it into this. If you've never seen the ultrastructure of the proton pump, it's just hard to describe in words. It looks like a stator on an electrical motor, if you're familiar with that. It's got a rotating base and a central pole, and the protons are just rotating around and coming out of the cell into the lumen. It's just it looks like a human designed it. It's quite phenomenal if you ever want to look that up. So this is overly simplistic, but proton secretion occurs here via the vacuolar proton pump. On the basolateral membrane of the cell is an anion exchanger, or a chloride bicarbonate exchanger, that we now know is AE1. Remember, AE1 is the most common protein in a red cell. 60% of the red cell membrane is made by AE1. It's in the red cell, it's responsible for taking carbon dioxide from our tissues to the lung for exhaling. But in the intercalated cell, it's responsible for getting bicarbonate out of the cell, but it does so in exchange for chloride. Now, where did the bicarbonate come from? Well, I didn't show the entire bicarbonate buffer system here, but for every proton that's secreted into the lumen, you generate one bicarbonate ion. That's where it comes from. And it doesn't stay in the cell. It leaves on the other membrane into the renal vein. This is the blood side. Okay. But the key concept here is there's also a voltage on the apical membrane of the type A intercalated cell, and it is negative inside compared to the outside, just like the principal cell. So that If you somehow depolarize that apical membrane, this is now depicting an intercalated cell, not the principal cell. If you depolarize that voltage, let's say taking it from -15 to -5, less negative, another way of saying it, you're going to enhance proton secretion. Whereas if you proton being the same charge as potassium, positive charge will have less difficulty leaving the cell as opposed to what it had before. I'll go back and just show that. Hyperpolarizing it would decrease proton flux. So again, the proton, like potassium, has difficulty coming out. It's going against an electrical gradient. It's negative inside. It wants to stay in compared to the outside. There is some sort of driving force. You may not know, but the pH in a normal cell is 7.15 or 7.2. So there is a proton gradient to leave, but the electrical gradient is opposing it. So to the extent that you can depolarize the cell and make this less negative, you'll enhance proton secretion. So it's sort of the same thing. To the extent that you hyperpolarize the cell, you're going to prevent proton secretion. So then we have to ask, well, what are we talking about? We're only hyperpolarizing and depolarizing the principal cell. ENaC is only on this cell. How could the voltage on this cell change? Well, it does. So let's go back to Little syndrome or any situation where you have excessive sodium entering the cell. As I showed before, the apical membrane voltage in the principal cell will be depolarized. That will decrease the electrical gradient that potassium has to fight against and will enhance K secretion, which will account for the hypertension and the hypokalemia. But it turns out, and this requires some background knowledge in electrophysiology, when you have cells like this that are together along a cylinder, you get what's called electrical coupling. They're current loops. And I won't get into that today, but just take it at face value that changing the voltage here will change the voltage on the neighboring cell. And it ends up actually changing the voltage so that the voltage is less negative on the apical membrane here. Let's say it was -15, it'll go to -5. So the protons have an easier time coming out. So there's more proton secretion, more bicarbonate generation, and then more AE1 chloride bicarbonate exchange, taking the bicarb into the blood. That's helping with the generation of the bicarbonate from the kidney. It's a renal generative cause. Okay, so it is intercalated cells, not principal cells, that are mediating the acid-base changes. And one of the mechanisms is enhanced type A intercalated cell proton secretion, because indirectly through current loops, the apical membrane of the type A intercalated cell has been depolarized. So let's take the converse where we give a milleride. Milleride again should only be affecting the cell, but we know we get type 4 RTA. So it's just the converse question. How do you get a distal renal tubular acidosis when you have a drug only affecting the principal cell? And there we have the converse situation. Preventing sodium from coming in hyperpolarizes this membrane, and through current loops hyperpolarizes this membrane, and you get impaired H secretion on a voltage basis. There's nothing wrong histologically with the cell, and we haven't had a drug that bound to this cell. It's all indirect through current loops. So the reason here, or one of the reasons we get increased H secretion and bicarbonate absorption, is because we've depolarized the apical membrane voltage in these patients by having excess sodium entering through ENaC. And therefore we have enhanced proton secretion by the type A intercalated cell. Now, there's another effect that's going on, and that is something called enhanced paracellular chloride absorption. And the protein is known. It's called claudin 4. It's one of the tight junction proteins. There's a whole series of different claudins throughout the nephron, some of which are mutated in different disorders and in mice models, but they mediate the paracellular transport of ions. It actually, it's been known for many years, you don't just have the protein going through between the cells. There's actually, or the ion going through between the cells. There's actually proteins there that the ion is transported through. So now we have another thing we've added to this to these cell models, and that is between the cells we have chloride moving. Okay, and they're going, and I'm not showing Claudin 4, but it's in the tight junction here between these cells. And chloride moves against a concentration gradient. Remember, chloride in the blood's 100 and the lumen is less, but there's a voltage here between the blood and the lumen. So this is another type of voltage. It's not an apical membrane voltage. It's called a transtubular voltage or transepithelial voltage. So it's another driving force that ions that go between the cells will see. So ions see voltages across a particular membrane. I'm not even showing the voltage across the basolateral membrane for simplicity here. But to be complete, there's a voltage here, a voltage on the basolateral side, and there's a transtubular or transepithelial voltage. Each voltage will affect its own membrane here, and we call this transcellular transport. Between cells, we call that paracellular transport. And again, it will occur if there's an favorable electrochemical gradient. Now, the chemical gradient for chloride is not favorable because the lumen has a lower concentration in the blood, but there's an electrical gradient that if it's sufficiently positive in the blood compared to the luminal urine side, will counter that chemical gradient and you'll end up with net transport between the cells. So the voltage here typically varies. It depends on how much mineralocorticoid is present, number of factors. It's not very high. However, if you have a depolarization of this apical membrane, it indirectly also affects the transepithelial voltage. I won't get into how that occurs, but just again, take that as a fact that when you change the voltage on the principal cell, you change the voltage secondarily on the intercalated cell, and you change the transtubular or transepithelial voltage. And you actually make it significantly more negative in the inside compared to the outside. And the more negative it is compared to the outside, the more chloride transport you're going to get. So what happens is in Little syndrome is you have enhanced paracellular chloride transport in this nephron segment. So we have enhanced sodium absorption, enhanced chloride absorption, and enhanced K secretion and enhanced proton secretion. The enhanced sodium chloride absorption causes the volume expansion and your hypertension in these people. But the enhanced chloride absorption does something else. It lowers the luminal chloride concentration. And that has effects on this cell, the intercalated cell also. So there's increased H secretion and bicarbonate absorption via the type A intercalated cell because of the lower luminal chloride concentration actually lowers the cell chloride concentration. Show that here. So if you have enhanced chloride absorption here, you're going to lower the chloride in the lumen. This cell sees that. And the cell chloride is going to drop. And when the cell chloride drops, you have stimulation of A1 here. Chloride enters the cell more easily and bicarbonate leaves. So this is a second reason why type A intercalated cells secrete more protons and absorb more bicarbonate in Little syndrome. You have the voltage effect, and you have this effect of driving more chloride out of the lumen, enhancing A1 transport and coupled proton transport. So these two factors are what are stimulating the type A intercalated cell to generate and absorb more bicarbonate into the renal vein, causing the metabolic alkalosis. Now, there's another factor, and that is that the enhanced paracellular chloride absorption also affects bicarbonate secretion by the cortical collecting duct. Now, remember, as I talked about last week or a couple of weeks ago and before, the cortical collecting duct doesn't only absorb bicarbonate by the type A intercalated cell. There's another intercalated cell there. This is the third of our three cell types that secretes bicarbonate into the lumen. And what the cortical collecting duct does in a net sense depends on the bicarbonate absorption via the type A intercalated cell relative to the bicarbonate secretion via the type B intercalated cell. Now, the type B intercalated cell has a chloride bicarbonate exchanger called pendrin that we talked about. It's mutated in Pendred syndrome, which is a thyroid disorder because it also transports iodide. But in the cortical collecting duct, it's an anion exchanger like A1. but it's configured on the apical membrane and it doesn't absorb bicarbonate, it secretes bicarbonate. But the bicarbonate secretion is very dependent on the luminal chloride concentration. And we talked about that, and that's how we talked about in weeks past, when you give chloride, why you can correct a metabolic alkalosis that's chloride sensitive. It's because you're giving chloride to the lumen of the cortical collecting duct from your IV when it gets down the nephron to that site and allows pendrin to work again. Without chloride, pendrin shuts off. And that's why you can't correct the metabolic alkalosis in the chloride sensitive patients in a vomiter, for example, until you give chloride. But what's happening in Little syndrome is pendrin also is shut off. It's shut off because the luminal chloride has been dropped, not because you're vomiting or not because you have congenital chloroduria, not because you have extrarenal chloride loss, but because you've driven chloride excessively paracellularly because you've enhanced the transtubular voltage in the cortical collecting duct. So this is an intratubular voltage effect when you enhance ENaC function that drives more chloride out of the lumen. But the net effect is the same. You've lowered the luminal chloride concentration, and now pendrin stops. So we have another mechanism then for why they get a metabolic alkalosis. We've impaired chloride secretion or bicarbonate secretion via the type B intercalated cells. So the two main acid-base effects in Little syndrome that cause the metabolic alkalosis and prevent it from being corrected are part of the so-called maintenance phase also, the generation of maintenance. It's all cortical collecting duct. Is because of increased proton secretion and bicarbonate absorption via the type A intercalated cell due to, number one, membrane depolarization from our current loops, and secondly, lowering the luminal chloride concentration from the pericellular chloride transport so that we lower the intracellular chloride and stimulate AE1 on the basolateral membrane. And secondly, we affect type B intercalated cell secretion by lowering the luminal chloride concentration. We impair pendrin-mediated transport of secretion of bicarbonate into the lumen. So let's get back to our patient. So the second you see this, your brain should go, there's two causes. Number one, it's the cortical collecting duct. That's where ENaC is. So we must be talking about that segment. And two, there's two different types of intercalated cells that are involved. One that secretes bicarbonate that's shut off because of the low lumen chloride, and one that absorbs bicarbonate and it's shut off because of the depolarization, or excuse me, it's stimulated because its apical membrane was depolarized through current loops, and also the low luminal chloride ends up stimulating basolateral AE1 and enhancing bicarbonate absorption through the cell that way. And that's how the bicarbonate's elevated. It's not anything directly due to ENaC, and it's not the principal cell. If we didn't have intercalated cells, we would only have hypokalemia and we would have volume expansion, hypertension, and our bicarbonate would be normal. So again, just going up 30,000 feet, Little syndrome is a cause of hyporenin and hypoaldo. It's autosomal, one of the many causes. It's usually pediatric. They have hypokalemia and metabolic alkalosis, hypertension, genetic testing if you have it. Treatment is to block ENaC with amiloride or triamterene, as you might expect. And you can block it. It's just that, there's many channels there. They still bind amiloride just fine. You just have to bind them and stop the function like you would normally when you give amiloride. And mineralocorticoid receptor blockers have been found to be ineffective. So let's go back to our main diagram. And what I'm doing here is I'm fine-tuning what we had for sodium before. And now we can, because of what we've gone through, add this other factor, which can be involved in the generation and maintenance of a metabolic alkalosis. And that's the sodium transport, not the concentration, but the transport that occurs across the principal cell via ENaC. And I didn't write all of that here. But that transport rate, one extreme being Little syndrome, the other extreme being someone on amiloride, will definitely affect through current loops and the luminal chloride transport via the type A and type B intercalated cells. And with the right circumstances, lead to a metabolic alkalosis or a distal RTA. Distal RTA is just the converse, where you hyperpolarize the membrane voltage and make it harder for protons to be secreted. You increase the luminal chloride, you keep bicarbonate secretion going. You're still secreting bicarbonate, but you're impairing absorption, and they end up with a distal RTA on a millerite, a type 4 RTA. The hyperkalemia occurs because you've hyperpolarized the membrane voltage in the principal cell. Just the converse thinking. Mirror image a little syndrome. You can memorize one, you can predict the other. I've also put here, not the transport, but what the luminal sodium concentration is, because if you think of it, when you go on a milleride and hyperpolarize the apical membrane, well, what happens if you're volume depleted? People talk clinically about distal sodium delivery, but that's a horrible, meaningless term. The nephron doesn't measure how much sodium is coming through the lumen per unit time. The cells only see concentrations. That's all they can see as far as electrochemical gradients. There's no sensor counting how many sodium ions come through per unit time. I just hate that term, distal sodium delivery, even though you'll hear it all the time. But if you think of it more logically and with more resolution, when you volume deplete a patient, what you're doing is you're avidly increasing proximal tubule and thick ascending limb sodium transport. So by the time the sodium gets to the chordal collecting duct, the concentration of sodium in the lumen is low, and ENaC is fine. However, the amount of sodium transport per unit time that can go through ENaC is less. So that's another example where you're going to hyperpolarize the apical membrane, not because you've put the patient on a milleride and blocked sodium transport, but you've decreased it, not because you've done anything to the ENaC channel, but you've impaired the electrochemical gradient for sodium by lowering the luminal sodium concentration, because there's just so much sodium absorbed prior to that segment. And so in effect, you create what looks like someone on a milleride. So volume depletion can lead to less ENaC sodium transport, less potassium secretion, so they get hyperkalemic, less proton secretion via the type A intercalated cells, enhanced basolateral, impaired basolateral chloride bicarbonate exchange, less bicarbonate coming into the renal vein, and what looks like a distal RTA. So these two things sort of are together, but they have very different mechanisms. So I've listed them separately. So the bottom line conceptually is that sodium transport via ENaC can be changed. Either you've altered ENaC and you've done nothing to the sodium gradient, or you have situations where you have less sodium in the lumen as far as concentration in a volume depleted patient with vomiting or diarrhea, that sort of thing. Or if you give an IV of sodium, you're actually enhancing sodium transport via ENaC. So it can be modified by the sodium gradient also that you will do clinically every day in your practice. But remember, you're altering what ENaC is doing. That's always the bottom line. And the next thing that's happening is you're altering the apical membrane voltage in the principal cell, which is solely dependent on not solely, but to a large extent, dependent on ENaC. Okay, so I think I'll stop there today.